little more flexion adjusted, right? Flex the spine. I don't want to do this. I don't want to complete the compression on the nerve root. So even when I adjust, I may want to round out that lumbar spine a little bit more before I do my manipulative side posture adjustment. When I stretch him, he may have relief in flexion by provocative M3D testing. Or, oddly enough, he may have relief in extension because the spine is never what it appears on MRI. You've got to do the provocative testing. But in lack of provocative testing, the first choice of positioning would be flexion. So through stretching, we're going to open up that lateral recess. We're going to bring back the disc, right? Part of the rationale of why traction works is it retracts the nucleus back to the center, centralizes the nucleus. It begins to align the cartilage of the annulum, fibrosis, brings fluid in to hydrate the disc. So I'm going to open up. My object with you is to open up this space, to bring the tissue back. So if somebody comes in with this room, this room, this room, this room, and it's all arthritic, I'm kind of not going to have the same clinical success, and I'm a happier chiropractor and clinician when I see this bulge, this bulge, this bulge. I have a fighting chance. Chances are I'm not going to be able to just affect the facet. If that facet is so huge and hypertrophy and crushing into that, it's giving an intermittent coordination. My clinical success is less than if there is soft tissue involvement that I can get to through three-dimensional decompression with the right movement. Yep. So, we'll move on to the next slide. Here's the cross-sectional area of the same area of the fecal sac. And here's the difference of the serrated lines, interrupted lines, are extension. This is the area of the spinal canal. So here you have less distance, interfacet distance. That's why they put these lines in, interfacet difference. Is the spinal canal being squeezed? Or the lateral recess is being compromised up in here. And we can see the area is greater in flexion. So a lot of the stenosis cases, I'm going to put them in flexion, commonly, but always with lateral flexion, if there's a lateral flexion component, right or left. We can see here from the chart that sagittal diameter is 10 millimeters. Put them in extension, 7 millimeters. Precipitous drop in area of the dural sac, ligament is interfacet diameter, etc., etc. Here's another great study by Schoenstrom and Lindell that taking the spine, putting it in flexion and extension, under compression and distraction, produces similar results, similar findings. Here is in flexion, there's an increase in canal size in the cross-sectional area, increase in the mean sagittal diameter, top to bottom, and the ligamented flavum decreases with flexion. Stretches. So I can create some stretching of the ligamented flavum, thinning it out, and open up the canal or lateral recess more by doing that. So I can affect the soft tissue through this. Same thing, that through stretching, flexion and extension, the comparison is 50 points different, millimeters different, squared, and the area 40 millimeters difference. Compression is found worse to close the canal than extension. Slight difference. Patients may get better under extension, however. You have to test the patient and place them in that position. Shinabo, Watkins, and Dillon, my favorite study, they took a catheter, placed it against the L5 nerve root to mimic the disc where the disc was, and moved the patient in flexion extension, and they found out that extension moves the nerve root away from the disc. So it's not so crazy that some of these patients will have relief in extension, but you've got to test for it. basically physical therapy testing. I like this test because it basically indicates that if you have a real bad disc patient and they can't achieve some kind of extension, in half of these cases of the 67 patients, the other half goes to surgery. So extension positioning is a good prognosticator of clinical outcome. Here are the McKenzie exercises. I've been in practice a lot of years, and I really don't see great benefit in this other than clinical testing. But when you take these positions and you combine them with simultaneous dynamic movement and traction, decompression, you have a winning combination. And that's what these devices do. How about when I say that discs can be retracted through traction? Here's evidence. Plastic casts, 100 pounds necessary to achieve distractive force, change in this in retracted nuclear material. Medial disc, easier to treat. Posterior lateral, second disease. Lateral disc, harder to treat because it's in a lateral recess. The study of Ramos and Martin showing lowering of intradiscal pressure through decompression. Cox showing flexion distraction courses. These tests have no outcome effect. We don't know what the effect of low intradiscal pressure is. Whether it's just a phenomenon that happens like doing the adjustment and gaining the osseous sound. We don't know if there's a clinical benefit to lowering intradiscal pressure. I think it's mechanical. I think because of all the movements on the devices like the Cox, like the Extentrac, the reason why you're getting clinical results is chiropractic-based movement, mobilization, stretching, adjustment that takes place as you're dynamically moving in different positions and you're working on the cassettes and the disc and the joint. Just showing pressure drops. Cox's work, dropping into the negative range, below the negative horizon. And the original work by Natkinson on two routes of permeability through the surrounding synovial fluid, through stretching, and can increase theoretically the diffusion into the avascular disc to help bring all the nutrition that you recommend to the patient back into the disc, to heal the disc. 4 protocols, we discussed some of the protocols before, the dynamic, I think we saw the grease, we saw this, supine, manipulation we went over. I was called to treat a heavyweight champion of the world at the time with the beginning of the drop foot. And he had a right lateral, he had a left 405 dorsiflexion. And he had a target to the right, relief and forward flexion. Now he was in so much spasm, in so much pain, that he's really the one that I developed the vertical protocols on the Extentrac for. And at 2 o'clock in the morning with my crew there, couldn't get into the place he was staying. It was in a condo, and there was no place to treat him. So we treated him outside at 2 o'clock in the morning with lights and the truck and the crew, and began to stretch him. I didn't want to lay him horizontal because I felt that might injure him. And we used natural body weight slowly and gradually. And within the 2nd day, 3rd day, he was jogging, he was straight, and his strength came immediately back into his legs. So if you make the right positions, you're going to really help that neurologically recover and posture improve almost immediately. You don't necessarily have to go through 2 months or 3 months of continuous treatment to see improvement in posture. And you should also adjust the patient, adjust the axis, adjust the fifth circle, adjust the occiput, do the things as a chiropractor that you would do. Don't necessarily adjust the area of injury right away, right? But, you know, even though I would sit by my pool and read subluxation specific, adjustment specific, and really get into it because I really love it, I really realized that not every treatment for back that we treat is always found in the occiput. I'm sorry, it's not. You have to treat down here. So maybe DD was right, BJ was half right. So literally we began to treat him outside. Protocol 2, but before I put him horizontal, safe position is vertical. And if he proceeded in success this way, this is manipulation here, he's a big guy. Then I'm much safer this way, using natural body weight, 3D positioning, gradual, manual approach. Then we progress to protocol 2. Protocol 1 precedes protocol 2. Protocol 3 is extension, protocol 4, horizontal. My protocol 1 is for patients with pain in the visual analog scale and score of 5 or over. I never put them horizontal. I don't want to lay them down. I treat them vertical. Just sorry, that works better. I want 100% success. So when I treat a patient who comes into my office, my object is 100% outcome, 100% treatment, because it represents I represent the chiropractic profession. I don't want to fail. And if you want to have success in business, you're confronted with us as chiropractors, a tremendous competition from therapists and from pain management doctors. Here's a gentleman that I treated in Korea. Had 2 treatments and he was thanking me. These are the kind of results that you'll get. Both in chiropractic. Yes, sir. 5 minutes. 10 minutes? Okay. Heartfelt thanks. Right? Help them out. When and when not to adjust. You know when to adjust. Just don't adjust prematurely. Get some clinical improvement first. Get some reduction in spasm. Then go in there and make the adjustment. Successful patient education and management. Tell them what you're doing. Be sincere. I run a cash practice. I also run an insurance practice. So when I do a specific adjustment, I bill for that. When I do M3D Extentrac Decompression, it's cash. And it's non-ending cash. In this insurance environment, I know what you're all going through. Thank God I have Extentrac, because you build the brand to Extentrac. It's built a brand name for itself. That's not being a salesmanship effort needed to sell it. You get results. You get results with it. Or with other tables, if you apply these principles. And you're going to have MS patients and MS repeat patients. And you'll be able to compete with the best pain management doctors, the best surgical procedures. You'll have equal, if not better, outcomes than relying on surgical intervention that can damage the patient and injure the patient and cause repeat surgery. And you'll be able to treat post-surgical failures, particularly if you combine it with manipulation, adjustments. So we have the best of both worlds. And I believe that we should embrace modern technology into chiropractic, but not lose the respect for the tried and seasoned true technology of adjustments, which have to always be done. So one helps the other. One is not in lieu of the other. Thank you very much. I really enjoyed having any questions.